I'm going to give a brief talk on an approach to interstitial lung disease. This is a complicated topic. I just finished delivering a lecture to my medical service team, and there was a lot of information, and I'm going to try and talk a little bit about this entity with an approach to how you attack it. First thing is, these things are now called diffuse parenchymal lung disease. So, parenchymal lung disease. So ILD is kind of not in fashion, even though this is what it is. And these, as a whole, are diseases of the interstitium. But when classifying these conditions, sometimes people get confused. They put nodular diseases in there. They could put alveolar diseases, and they could all fit in this one gap of ILD, or diseases in the chest that are not COPD. So it's complicated. So how are we going to handle this and classifying it? I think the best way to look at this are the rule of I's: idiopathic, inflammatory, idiopathic local, and idiopathic systemic, inflammatory, infectious, inhalational, and occupational, organic, and inorganic. Okay, and you're going to have to excuse my handwriting. It's illegible. I'm doing this more for myself than for you. Okay, so idiopathic pulmonary fibrosis. This is IPF, okay, and this is the classic disease we think of. There are histologic patterns that you see, and these have been described really 40 years ago, plus UIP, NSIP, DIP, resident with interstitial lung disease, LIP, BOOP, and AIP. And it's important to understand what these are. The most common pattern you see with interstitial lung disease, idiopathic or that due to connective tissue disease, is something called usual interstitial pneumonitis. The pathologist reads that. It's usually a mixture of normal lung inflammation and fibrosis. The more advanced the disease is, the more fibrosis you're going to see. And you have to remember the major player here is the fibroblast. That's what's driving the pathology. NSIP is sort of like UIP, but it has a better prognosis, and it's more diffuse, and it's more steroid responsive. UIP is usually lower lobes, NSIP are all over. DIP and RBILD, these are not as common. These are interstitial lung diseases specifically associated with smoking. It's a good board question. Once in a while, you'll see a smoker with interstitial lung disease, and you ought to think of these. LIP, lymphocytic interstitial pneumonitis, is not a real common thing. This is associated with Sjogren's syndrome and HIV. BOOP, bronchiolitis obliterans organizing pneumonia. That's what it used to be called. Then it was changed to cryptogenic organizing pneumonia, and now it's just called organizing pneumonia. This is more localized, not diffuse. And the clue to this is, and it's not always idiopathic, patient presents like pneumonia, you give them antibiotics, they don't respond, you give them steroids and they respond. This is the most responsive to steroids. And if you do a biopsy, you're going to see bronchial plugging, but you're also going to see organizing pneumonia with this in pathology. AIP is acute interstitial pneumonitis. These patients are usually very sick, and they look like ARDS, but it's not secondary to sepsis or aspiration. It's sort of like idiopathic ARDS, and they're treated with high-dose steroids. But these are the pathologies. So interstitial pulmonary fibrosis, the idiopathic form, you have to think of. There's an association of this with GE reflux also. The next condition I want to talk about is sarcoid. Sarcoid we see, this is an idiopathic disease, but it's systemic. Most common organ involved is the lungs. Lungs involve about 90% of patients with sarcoid. This, in addition to being a restrictive interstitial lung disease, also can involve the bronchioles, and you can have mixed obstruction and restriction. And classically, you stage it. Stage 1, the hilar nodes involved, nothing else. Stage 2, hilar nodes and interstitium. Stage 3, interstitium, no hilar nodes. Stage 4, chronic and fibrotic. Sarcoid more often will involve the upper emitter lobes, but sometimes you don't see those exact patterns. And usually it involves, you need to diagnose sarcoid, you need at least 2 organ systems involved. And sarcoid could involve the skin's the second organ, it can involve the liver, the eyes, the GI tract, the central nervous system. It could really have a myriad of findings, but the lungs the most common involvement, and this is an important interstitial lung disease. You have to think about this when you're evaluating somebody with interstitial lung disease. The next thing I want to talk about, inflammatory or connective tissue diseases. You can see the lungs involved in a lot of autoimmune diseases. So the diseases, rheumatoid arthritis, lupus, scleroderma, polymyositis, dermatomyositis. Let's talk about these disorders first. Rheumatoid arthritis can cause interstitial lung disease more at the lower lobes. You could also see lung nodules, pleural effusions. Pleural effusion is a low glucose, and pulmonary hypertension. Lupus could really cause a myriad of findings. Acute lupus pneumonitis looks like pneumonia, chronic interstitial lung disease, pulmonary hypertension, pleural effusions, pleurisy, and something I forgot to tell my house staff earlier today, a phenomenon known as the shrinking lung syndrome, where you have an elevated hemidiaphragm due to atelectasis. Scleroderma involves the pulmonary system in 2 ways. Interstitium, usually lower lobe, a UIP type pattern, but it could also cause idiopathic pulmonary hypertension. That's more associated with limited scleroderma, and the interstitial lung disease is more associated with diffuse scleroderma. Polymyositis, dermatomyositis could involve the lungs. Usually there are other findings. There's a variant of polymyositis I want you to be aware of called the antisynthetase antibody syndrome, which involves interstitial lung disease. Patients look like they have mechanics hands, a lot of wear and tear there, and they have a positive Jo1 antibody. You could also see lung involvement with pulmonary vasculitides such as GPA and EGPA and MPA, and there are usually other symptoms involved with that, and they usually don't have classic interstitial patterns, but they can involve the chest. And the other interstitial lung autoimmune disease, ankylosing spondylitis, could at times cause upper lobe fibrosis. Okay. The next group of things are inhalational and occupational, organic or inorganic. If they're inorganic, asbestos-related disease is something we see. Involves the lower lobes. Often you have pleural involvement, pleural thickening, pleural effusions. Unfortunately, you could also see mesothelioma and adenoCA of the lung with this. And silicosis, seen in sandblasters and other occupational situations. Upper lobes, involves the hilar nodes. You could see egg-shell calcifications. And then there's the spectrum of organic interstitial lung diseases, what's known as hypersensitivity pneumonitis. This could be acute, subacute, or chronic. And you need to do a good history. Often there's occupational exposure, or it could be related to hobbies or something inside. And then when the exposure goes away, the symptoms resolve. And that obviously involves a careful history taking. A few other things to think of here. Metastatic cancer to the lung, normally it's hematogenious, And you see lung nodules of various sizes. Once in a while, you could get something called lymphangitic spread, where it looks more like interstitial lung disease. This has been reported with pancreas, stomach, lung cancer, breast cancer, and lymphoma. The diagnostic test you're going to usually do initially to evaluate these is something called a high-resolution CT scan. Takes thin sections through the lungs, and this has its own specific pattern. And then there's infections. TB could present a lot of different ways, and there are a lot of different infections. More often than not, classic infections are more alveolar and lobar than multifocal and diffuse, but they can be. And there's a lot more information here. Let me add one other thing. Drugs, you need a good drug history as far as what the patient's taking. Amiodarone, macrodantin, cancer chemotherapeutic agents, especially bleomycin have been reported to do this, but there are really a lot of different drugs that have been recorded to involve the lungs. And with this, I am going to stop. Thank you.